Hello guys, I will try to explain the differences between cochlear and retrocochlear hearing loss in this video. So let me start with a very simple diagram. So this is a diagram which shows cochlea. So what is cochlea is it's a sensory organ which is located in the inner ear. That means sensory organ means it detects the noise or sound impulses from the outside. So this is eighth nerve. So we know that eighth nerve carries the impulses that it receives from sensory organ, that is the organ of cochlear. So cochlear hearing loss means any pathology in the cochlea that is leading to hearing loss. A classical example for this is Meniere's disease. Meniere's disease, where there will be destruction of the outer hair cells of the organ of cochlear. Next is eighth nerve. Eighth nerve is an example for retrocochlear. So retrocochlear is basically anything behind cochlea. So that starts from eighth nerve till eighth nerve to brainstem or auditory cortex, we can call it. This is called retrocochlear because these are behind cochlea, retrocochlear. So a classical example for this is acoustic neuroma, which is a tumor of the eighth nerve. So basically, the retrocochlear pathology or cochlear pathology both will produce hearing loss. So the aim of this video is to differentiate between these two. This is an important MCQ frequently asked in NEET PG and more importantly in INICET. So before coming to the table, let's discuss about two phenomena. That is recruitment phenomena and another is rollover phenomena. So let's understand recruitment phenomenon is seen as Meniere's disease. So what is that means? Recruitment phenomena. So a small sound will be perceived as a loud sound. So these people who is having Meniere's disease, they will be intolerant to loud sounds because even the small sounds that will be perceived as a loud sound. Okay, let me try to explain the concept behind it. That's how I understood. So imagine in this is a normal person. In normal, we know that there are few thousands of hair cells, outer hair cells. Okay, so in many years, what happens is there will be destruction of this outer hair cells. So only few will be remaining, others are destroyed. Okay, so in menias, so what happens is in menias there are only few hair cells present and this will be hyperactive. That's how I understood. So that it will be perceiving even the small sound as loud sound. So recruitment phenomena is observed. So these people are intolerant to loud sound. Okay, I think I explained it. Next is rollover phenomena. In rollover phenomena, it is classically seen in acoustic neuroma. Okay, so basically retrocochlear pathology, as I have explained in the previously. So what happens here is the more you increase the sound, the lesser will be the sound perceived. Okay, I'll explain it again. So when you try to increase the intensity of sound, the patient will be perceived as a lesser intense sound. So this concept can be explained by the concept of nerve fatigue. So in acoustic neuroma, we know that this auditory nerve is involved. So there will be fatigue of this auditory nerve, so that when the sound intensity increases, there will be decreased perception of the sound. Now let's come to the table. Okay. So one thing we should keep in mind is a classical example for cochlear pathology or cochlear hearing loss is Meniere's disease, and a classical example for retrocochlear hearing loss is acoustic neuroma. And recruitment phenomena, that is intolerant to the loud sound, is seen with Meniere's disease. And rollover phenomena, that is when you increase the sound, the patient will perceive as a lower sound. Patient won't understand when you increase the sound. That is rollover phenomena that is seen in acoustic neuroma. Now let's discuss. So this is based on a pearl on marrow. So in this we can see recruitment present in cochlear hearing loss. It's absent in retrocochlear hearing loss. Now coming to the CC score, the short increment sensitivity index. What it means is that we have a instrument that will increase the decibel of the sound. Okay, a probe will be connected to the patient, and if the patient will be the examiner will increase the intensity. For example, initially it will be producing sound 5 dB, then next second it will be 6 dB, 7 dB, 8 dB, like that. Small increment will be making the intensity of the sound, and the patient will be asked if they are able to differentiate the sound. So in this, in normal people or retrocochlear hearing loss people, they will not understand this, they will not differentiate much, the increment in the sound. But in cochlear hearing loss, that is in the Meniere's disease people, they will have a high score because of the recruitment phenomena, because even the short increment will be felt as a big increment. That's a concept of recruitment phenomena, isn't it? Next is acoustic reflex threshold. So it will be decreased in cochlear hearing loss. Same concept, recruitment phenomena. So even a small sound will be perceived as a loud sound, so that their acoustic reflex will be threshold will be decreased. So in retrocochlear it will be increased. Next, tone decay and acoustic reflex decay. Both are a function of the nerve fatigue. Both are dependent on nerve fatigue. So nerve fatigue is observed in the retrocochlear hearing loss. So it is seen in retrocochlear hearing loss, not in cochlear and not in cochlear hearing loss. Next is autoacoustic emissions. So it is present in retrocochlear, it is absent here. So we know that autoacoustic emissions are produced by outer hair cells of cochlea. So in cochlear hearing loss, these outer hairs are destroyed, so that there will be no production of autoacoustic emissions. So in retrocochlear hearing loss, the cochlea is absolutely normal. The problem starts either with the eighth nerve or other parts of the auditory pathway. So it will be autoacoustic emissions will be present here. Now coming to Bera. So we know that in Bera, wave 1 represents the auditory nerve. Okay, auditory nerve. So in cochlear hearing loss, there will be delayed wave 1, rest are normal. Okay, so but in retrocochlear only wave 1 is present, rest are absent or affected. Let me try to explain this. Okay, so that we know that Bera does not test cochlea. That is the concept here. Cochlea will be absolutely normal. Okay, in Bera will not test for cochlear function. That's the thing. Bera test the from the eighth nerve to brainstem. That is eighth nerve, inferior colliculus, lateral lemniscus, superior olivary nucleus, cochlear nucleus. All these things will be measured by the Bera. So in cochlear hearing loss, cochlea is the damaged, but it will not be reflected on Bera. So Bera will be almost normal, but there will be delay in wave 1 because there is a delay in reaching the sound impulses to the auditory nerve. But in retrocochlear hearing loss, only wave 1 is present, rest are absent or affected. Okay. Next is speech discrimination score. So this is also a function of the eighth nerve. So by speech discrimination means, so we say certain words which are almost similar in sound. For example, pin, sin, kin. So the patient will be asked to identify, discriminate the sentences. So in people with retrocochlear hearing loss, their score will be very poor, out of proportion to the hearing loss. That's what we say. But in cochlear hearing loss, it will be reduced, but not as much as it is in retrocochlear hearing loss. So that I think I have explained cochlear versus retrocochlear hearing loss. So first thing what we should understand is cochlear hearing loss classical example is Meniere's disease, and another thing, recruitment phenomenon is seen in Meniere's disease. And retrocochlear classical example is acoustic neuroma, and rollover phenomena is seen there. With these two things, you can almost understand all the concepts behind that.